Dr. Atul KADHANE is the past secretary of the Maharashtra Ophthalmological Society, and he is going to enlighten us about iris claw IOL tips and tricks. Over to you, Atul.
Thank you, sir.
Yeah.
This side or this side? In this session of new IOLs, my IOL is quite old, 30 years and all. But maybe some of the tips and tricks, you may find it in the newer perspective. This side.
Dr. Gaurav, you are ready with the presentation?
So when you know, as you know that aphakia, when it happens as a surgical complication or it may have been traumatic, the options we have depends on whether you have a capsular support. If it is there, the best is 3-piece. Otherwise, we have all these ACs, SFIs, gluids. But instead of this, you have other options if you have a proper iris support, and that is the topic that I'm going to speak on, that is retrofixated iris claw IOL. Now, why I prefer it? It's easy to implant, shorter learning curve, less surgical time, very minimal instruments required, and the most important thing is for a comprehensive ophthalmologist like me, who is not VR trained, you don't need to be worried. And a proper central anterior vitrectomy is also sufficient for that. You don't have to go to the base like a trained VR surgeon. So another way is all those scleral fixated IOLs, whether it's glued or with sutures, or if you use to CMT flex, there is chances of serious post-operative complications like suprachoroidal hemorrhages, or maybe something deal with. As you are in more time you are in the anterior in the eye, the more chances of you are landing in a trouble. On the contrary, iris claw have a good post-op vision. The explantation is not that difficult as people thought, in case if you needed it. Almost every time you need a proper assessment of iris and pupil, a complete peripheral retinal evaluation. In fact, for every secondary IOL case, a proper biometry, a proper macular status, and a correct endothelial count, so that you should not end up in another problem. There are some risks involved, but this risk to the damage to the root or angle is minimized as most of the times, because ideally you have to enclave it in the mid periphery of the iris. So chances of pupil distortion is only there if you enclave it at the margin, or if you enclave it with the force. Chances of iris depigmentation is there, and a risk of anterior uveitis, but you will not find it that too much often a case just because you have done iris claw, so that the patient starts coming with an anterior uveitis. Difficulties you face if the eye is hypotonous, if the pupil is not of the particular size. An optimal pupil size is something around 4 to 5 millimeter. If it is there is a chance that you have to face a difficulty in the enclavation. But you can combine with pupilloplasty, and the enclavation part will be an easy if the pupil come down to a proper pupil size. Post-op complications are there, that like as I said, pupil ovalization, which happens only if you enclave it not at a proper site. There are chances of redislocation, and mostly it is because when you enclave at particular site, and after some years, if there is an iris atrophy at that site, the haptic may get disenclaved. So that time you have this redislocation, and even if the proper enclavation, even if you have a decentration, it doesn't mind if at all if it is properly centered on the pupil. So this can be dealt properly. There are few contraindications. If there is a gross iris abnormalities, or if there is a rubeosis iridosis, or in a post-vitrectomy eye where there is a profound iridodonosis, better avoid such iris claw lenses in such, and of course the patient with an anterior uveitis. So some of the tips, one is that is always this not for iris claw, it's all for secondary IOL implantation. You should check for vitreous in AC. There should not be any remnants of the capsules or any vitreous. You have to always see that it is free of vitreous. It has to be perfectly closed chamber surgery, so create and construct scleral tunnel, because these iris claw IOLs are mostly an optic size of something around 5.5. So you need to have an incision which is clear corneal incision is not going to be that sturdy. So this scleral tunnel will prevent you from protects you from the astigmatism part of view, and as well as from the endophthalmitis part of view. While doing a limbal paracentesis, you should prefer to be more on the scleral side. If you go more on a limbal side or on a corneal side, you will face difficulty in enclavation. So if you go it plane parallel to the plane of iris, it will make the job easier for you in the lateral side. Now, when you insert the iris claw inside it, and when you try to hold it with the iris claw forces, align the edge of the forceps with the gap in the IOL loop. Because as the IOL, when IOL goes inside, the haptic goes inside behind the iris, you are not sure whether exactly the gap is. Sometimes even if you lift it, you may not find out that particularly that dimple in the iris. But if you align with the edge of the forceps, then you know that here is the place I have to enclave. So that tip will give you a proper enclavation with a proper force at the proper site. And you can use any instrument, but most of the times I use best is a 27 gauge cannula, because that I feel is it's a handy one. It's not it's available in each OT. So there are a lot of studies from so many years since 1972 when it comes introduced, that iris claw proved a retrofixated iris claw lenses is a good surgical option for an aphakic patients. So any procedures, there are some problems with this, but the learning curve is less. The lowest number of post-op complications, as I found in this iris claw, and for a comprehensive ophthalmologist, this is a rescue surgery. He can do his own setup. He don't have to refer to patient to VR surgeon, or he don't have to be VR trained, or he don't have to be an advanced vitrectomy machine or something like that. So take-home message is a easier learning curve, good results if done properly. Good vitrectomy is a must, and it's comparable to other all options. Thank you.
Thanks a lot, Atul. Very nicely put up all the tips and tricks, and of course you have also alerted about the post-op complications and the things that you can face. But it's a very nice technique. It saves the day on that, and you don't have to refer to a vitreoretinal surgeon if you really master this technique. So it's very nice. Any questions from the audience if you'd like to ask?
Sir,
We can have one question at least.
you might have done hundreds of iris claw lenses. I would like to know your experience in terms of development of macular edema in these patients. Approximately how many percentage of patients develop macular edema?
You do get definitely. But what I find is in those patients where the vitrectomy part was not proper, some cases referred from outside after doing iris claw, and in those cases I found that the chances of macular edema was more. But still, in even clear-cut cases, but a patient is a case of uveitis in the past, something like that. If you ask those cases also, but not that much as it's been told to us that there are so many. I don't feel that it's there are no many cases.
Do you think decentration plays a very major role in visual disability after this IOL? Or in other words,
Unless
have you had...
until it is covered with the pupil, maybe you have a little bit of cylinder in
Can
your
we discuss
specs,
this,
but besides that, it doesn't matter, even if it's slightly decentered. But if the pupil is not, if the pupil is covered properly, then you don't have to do anything for that. At least I don't do anything.
Thanks, Atul.